Hello everyone, welcome to the another episode of Next Saviours Essential Question Series NEET PG 2025, where we are going to discuss one of the many topics out of adrenal disorders, and that is Addison's disease. I don't know how to explain this, but we gain that pseudo confidence as a NEET PG aspirant when we try to prepare for the adrenal disorders. When we see moon phase, the buffalo hump, the purple stria, the proximal muscle weakness, the specific findings of weight gain, depression, irritability, and psychosis, we know that this is Cushing syndrome. And when we see the features like episodic headache, palpitation, sweating, weight loss, anxiety, panic attacks, we are confirmed that we are dealing with pheochromocytoma. And on the other hand, when we see like hypokalemic muscle weakness, metabolic alkalosis, and not so common psychiatric symptoms, then we are almost confirmed that we are dealing with a Cushing on Con syndrome. So we gain that pseudo confidence. But when in reality, the Addison's is never compared with this Cushing pheochromocytoma or the Con syndrome. Rather, the real deal is that the Addison's is asked in context to the secondary adrenal insufficiency, the congenital adrenal hyperplasia, the hypoaldosteronism, or adrenal tuberculosis, or the adrenal metastasis, because these are the things which are usually kept in the options. And why not? Because many of them are the adrenal insufficiency disorder, right? So several adrenal disorders can present with the overlapping symptoms. And in order to differentiate these conditions, we have to understand the basic pathophysiology, the clinical presentation, and laboratory findings with a very thin line of difference. And then only there is a possibility that we can reach the possible diagnosis. And this is exactly what we are going to talk about. We'll be talking about the differences of the Addison's disease with that of the secondary adrenal insufficiency, congenital adrenal hyperplasia, hypoaldosteronism, and the adrenal tuberculosis or adrenal metastasis, which are in real kept in your question related to NEET PG examination. So this is the kind of the sample question that we'll be talking about later. Let's start with the differences straight away. So you see the first one, or the first feature obviously, is that the Addison disease is the primary adrenal insufficiency. So the ACTH levels obviously are going to be high. But in secondary adrenal insufficiency, as you know, that the ACTH levels are usually low or normal because of impaired, insufficient secretion of ACTH from the pituitary gland. So it is resulting in reduced stimulation of the adrenal cortex and decreased cortisol production. So as a result of which, it could be either low or normal, the ACTH levels. Now, as it is very clear that the in congenital adrenal hyperplasia, the ACTH is usually high, which is because of the loss of the negative feedback from low cortisol levels. As the enzyme deficiencies, as you know, that most common enzyme deficiency which is seen in CAH is 21 hydroxylase deficiency. So it impairs the cortisol synthesis, prompting the pituitary to increase ACTH secretion, as a result of which there is a high level. Now, in case of hypoaldosteronism, the renin-angiotensin system, it primarily regulates the aldosterone secretion from the adrenal cortex and has a minimal direct impact on ACTH level, as a result of which it is found to be normal or slightly elevated. It all depends upon the renin-angiotensin feedback. In case of adrenal tuberculosis or metastasis, because the adrenal cortex is damaged or destroyed, it is usually higher. The ACTH levels are higher. So that is the first point. Now, the second one of the prominent features would be provided to you is the skin hyperpigmentation. Now, first of all, try to understand that why there is a hyperpigmentation because of raised ACTH. Because, skin hyperpigmentation occurs in these conditions because ACTH shares a common precursor, which is pro-opiomelanocortin, that is POMC. So when ACTH levels are elevated, there is increased production of MSH, that is melanocyte stimulating hormone, which stimulates melanocyte to produce more melanin, leading to hyperpigmentation of the skin and the mucous membrane. So this is the reason why we are having skin hyperpigmentation in case of Addison's disease, in case of congenital adrenal hyperplasia, and in case of the tuberculosis or the metastasis, where ACTH is usually higher. As far as this aldosterone deficiency is concerned, so the primary defect for aldosterone deficiency is a feature of hypoaldosteronism. Now, another very important thing that is always provided is the electrolyte imbalance. You see, aldosterone normally promotes sodium resorption in the kidneys, And in its absence, the sodium is lost in urine, leading to low serum sodium levels in case of Addison's disease. Additionally, the cortisol deficiency results in increasing the antidiuretic hormone secretion, causing water retention, which further dilutes serum sodium. So, hyponatremia is a feature of Addison's disease. Now, why hyperkalemia? Because aldosterone also facilitates the potassium excretion by the kidneys, and without sufficient aldosterone, potassium is retained, resulting in elevated serum potassium levels. So, hyperkalemia is seen in. Now, in secondary adrenal deficiency, what happens is that aldosterone secretion remains intact. Unlike cortisol, which depends on ACTH from the pituitary, aldosterone is primarily regulated by the renin-angiotensin system, not the ACTH. So, since aldosterone production is unaffected, sodium and potassium balance remains normal. As a result of which, thereby, there is normal potassium level. And this is a key distinguishing feature or a specific finding for secondary adrenal insufficiency. Rest in all the other cases, they are having hyponatremia, hyperkalemia, right? Now, another common finding is that of the hypoglycemia. Now, as you already know that cortisol, it is responsible for playing a crucial role in maintaining the blood glucose levels. How? One is stimulating gluconeogenesis in the liver. Second is enhancing the glycogenolysis, which is breakdown of glycogen to the glucose. And the third one is the counteracting insulin to prevent excessive glucose uptake by the cells. You see, if there is inadequate cortisol or without adequate cortisol, these processes are impaired, leading to reduced glucose production and increased insulin sensitivity. So it results in hypoglycemia, particularly during stress, fasting, or illness. So hypoglycemia is seen in all except for the hypoaldosteronism because the cortisol levels are normal relatively. Now, one specific finding on the basis of which the question is structured is that of the blood pressure. What is the reason for severe hypotension which is seen in Addison's disease? Severe hypotension or orthostatic hypotension in Addison's is due to the combined effect of both aldosterone and cortisol deficiency. How? Aldosterone, which is responsible for normally promoting the sodium and water retention in the kidneys, so its deficiency results in the sodium loss, that is hyponatremia, and water loss. So, thereby reducing the blood volume and contributing to the low blood pressure. On the other hand, how cortisol is responsible for this? Because cortisol enhances the vascular response to catecholamines like adrenaline by maintaining the vascular tone. So, without cortisol, there is a reduced vascular responsiveness to vasoconstrictors, as a result of which it results in vasodilatation and further hypotension. So, the combination of both hypovolemia and vascular collapse, it results in severe hypotension in case of the Addison's disease, right? Next is the only specific finding for congenital adrenal hyperplasia is the ambiguous genitalia or virilization, which is seen as a genital abnormality. In rest of the all the other cases, all the other differentials, it is absolutely normal. So genital abnormalities in congenital adrenal hyperplasia are primarily due to excess androgen production, which resulting from the enzyme deficiencies in cortisol synthesis. And as you know, most common it is the 21 hydroxylase deficiency. Right now, one thing which will always be provided to you are the response to the ACTH stimulation test. In Addison's disease, the response is blunted, while the response is normal or delayed in case of secondary adrenal insufficiency. Now, this thing is important because of the hormonal test. Hormonal tests are important as far as the diagnosis of or the comparison of the primary and the secondary adrenal insufficiencies are concerned. So one of the hormone test is baseline morning serum cortisol and ACTH level, which you already are aware of that it is taken at 8 a.m., right? The baseline levels. And what is the interpretation? Like if there is low cortisol and high ACTH, then it is indicative of primary adrenal insufficiency, that is Addison's disease. On the other hand, if there is low cortisol but there is low cortisol or inappropriately, you can say normal ACTH. So at 8 a.m. in the morning, then it is suggestive of secondary adrenal insufficiency. On the other hand, the another hormonal test is the ACTH stimulation test, or also known by the name of co-syntropin test. Now, it is obviously it is the gold standard for confirming the adrenal insufficiency. And what is the involvement? The procedure is that first you measure the baseline cortisol. The second thing that you administer 250 microgram of synthetic ACTH, that is cosyntropin, which can be given intravenously or intramuscularly. And then you measure the serum cortisol level at 30 and 60 minutes post injection. And based on the results, the interpretation is made. Like if the cortisol level is less than 80 microgram per deciliter post stimulation, then it is suggestive of adrenal insufficiency. If the response is blunted, that means there is no rise in the cortisol level, it is primary adrenal insufficiency. And if the response is normal or there is a delayed rise, then it is secondary adrenal deficiency. So, this is what exactly we have discussed or talked about in case of these disorders. Like in case of Addison's disease, there is a blunted response or no response to ACTH stimulation test. Why there is blunted or no response? Because the adrenal cortex is damaged and cannot produce cortisol even when it is stimulated by exogenous ACTH. While on the other hand, the response is absolutely normal or delayed. This occurs in case of secondary adrenal insufficiency because the adrenal glands becomes atrophic over a period of time due to chronic low ACTH levels from the pituitary dysfunction, reducing their ability to produce cortisol immediately. So in early stages, the adrenal glands might show the normal response to exogenously administered ACTH, but as the insufficiency progresses, there will be a delayed response. As far as imaging findings are concerned, these are absolutely normal. The imaging findings are going to be present in the form of calcification for tuberculosis or in the form of a mass in case of metastasis, and the autoantibody test is positive for Addison's disease. So, in total, this is how you are going to differentiate in between these 3 to 4 differential diagnoses which are usually kept in the question, and there is a very thin line of difference. Majority of the times the answer is constructed based on the hormonal tests which are kept in the question. All right. So as far as this Cushing syndrome, the pheochromocytoma or the Conn syndrome are concerned, these are other questions. These are not never combined with the Addison's disease. So if you look at the question now, a 35-year-old woman presents to the clinic with the complaints of fatigue, generalized weakness, unintentional weight loss of 5 kg over the last 3 months, frequent episodes of dizziness, especially when standing up. So this is suggestive of orthostatic hypotension. She mentions increased skin pigmentation, particularly on the elbow, knee, and gums, which, as you know, hyperpigmentation that we have talked about, which she attributes to sun exposure. Although she spends most of her time indoors, she also reports salt cravings and occasional nausea. On examination, her blood pressure is low while supine, dropping to 70 to 50 upon standing. Hyperpigmentation is noted in her buccal mucosa and the palmar creases. As far as laboratory investigations are concerned, the serum sodium level, like we have already talked about, it would be low. The potassium levels are going to be higher. Glucose level will be slightly on the lower side. Morning cortisol levels are also low, and the plasma ACTH are found to be elevated. So on ACTH stimulation test, so once the ACTH stimulation test is performed, it showed a blunted response. That means minimal rise in the serum cortisol levels post administration. So by this time, you have already reached the diagnosis, and the answer for that question is nothing but the primary adrenal insufficiency. You have to initiate hydrocortisone and fludrocortisone replacement therapy. Hope you have understood everything related to this very confusing and important topic. All the best for your future endeavors, all the best for your future examinations. Be careful, be thoughtful, be less stressful. Thank you very much for listening. Join our Telegram group. The link is given below.